Okay, so Kelly asked me to do a talk on just sort of setting the stage for some of the other talks that you're gonna hear later today, and sort of talk in general and introduce sarcoidosis a little bit. Some of you probably know a lot of the material I'm gonna go over, but hopefully some of it is new to you. So my objectives are to review the potential causes of sarcoidosis, how we go about making the diagnosis, like how physicians approach a patient with sarcoidosis, organ involvement, and I'm going to do very briefly, I think somebody else, maybe Dr. Boffman is going to talk about treatment later on. So I'm just going to do a very brief introduction into that topic. So sarcoidosis was actually first described by this physician, this scientist, Dr. Jonathan Hutchinson, back in the 1800s. And it was first described as a disease of the skin. And it took a few more decades after he first described it to call it sarcoidosis. But that's when it was first described. So how is sarcoidosis defined? So the official definition of sarcoidosis comes from a paper from 1999 that's actually in the process of being updated at this point by some of the other speakers that you're going to meet later today. So the official definition is it's a multi-system disorder, which means that it can affect many parts of the body. The cause is unknown. It primarily affects young and middle-aged adults, and that when you do a biopsy, the hallmark of that biopsy is something called non-caseating granulomas. So you guys might have heard the term granuloma from your doctors. So basically, so again, in summary, affects lots of systems. We don't know what causes it. It usually affects young and middle-aged people, and granulomas are seen on biopsy. So in terms of organ involvement, as probably many of you know, that different organs can be involved, and different patients have different combinations, or maybe just one. So one of the studies that we got a lot of information on this was a landmark study that was published in 2001, published by Dr. Boffman, that took a cohort of 736 patients from 10 centers across the country and kind of looked at what were all the organs that were being affected by sarcoidosis. So the lungs were the most commonly affected. That's why so many lung doctors are sarcoid doctors, because the lungs are very commonly affected. So 95% of those 736 people had lungs that were involved. After this, the top two after that was skin and lymph nodes. Eye was pretty common, liver was pretty common. Erythema nodosum is a form of sarcoidosis affecting the skin as well, and subcutaneous tissue. So as you can see, lots of different types of organs being affected, with lungs being the most common. I just want to point out heart was lower on the list, so only 2.3% of the patients had heart involvement in this study, and then brain was involved about 6% of the time. So that was a really important study. That was the first multi-center study that was published in sarcoidosis. So in terms of the cause, what do we know? So we know three things for sure. We know that your genetics matters. We know that the environment matters. So what you're exposed to in your environment, your potential, so things like your occupation, viruses, bacteria. So we know that genetics matters. We know that your exposure matters. And then one other thing that I kind of don't have in this picture is your immune system being overactive matters. So a combination of those things is what's most important. Now, this is a really enormous simplification of what we know about the cause of sarcoidosis. But just for me to, in order just for me to stay on time and to not get too deep into some of these, I just sort of left it at this. And I always get questions about this this topic in particular, so I'm sure we'll talk about that in a little bit during the Q&A. So that's, and like I said, there's been lots of studies in the exposure part. There's been lots of and ongoing studies, some that we heard about during this conference that we've been having in the genetics part, and then lots of work being done on the immunology side of sarcoidosis as well. So how do I approach a patient with sarcoidosis? So when I have a patient come to me in my clinic at the University of Florida, I always explain to them that it's a process, and the process starts with me making sure that sarcoidosis is really what you have. And the reason I say that is, many people call sarcoidosis the great mimicker. And what they mean is that it looks like so many things. There's no specific symptom that says, aha, you have sarcoidosis, or chest x-ray or a CAT scan finding that definitely says you have sarcoidosis. And even in patients who we biopsy and we get the granuloma, we spend a lot of time scratching our heads, making sure that it is sarcoidosis and not something else. When I used to work at the Cleveland Clinic, the thing I worried about most is an infection called histoplasmosis, which is a fungus that's in the environment and lives in the environment in the Ohio River Valley. And the reason that's really important is because histoplasmosis also gives you granulomas, but if you gave a patient with histoplasmosis steroids, you could really harm them because that infection could get out of control. So for me, this step is really important. Does my patient have sarcoidosis? And the main reason for that is we don't want to cause harm by saying it's sarcoidosis and it really isn't. And I have a lot of patients that get stuck at that step and come to me to seek additional guidance. So, and I'm going to talk about that in a little bit. The second step, once I confirm the diagnosis, the next step I do is to ask my patient questions and do testing to figure out what are all the organs that are involved. Some of my patients just have just their eyes, just their skin. Some of my patients have 6, 7 organs that are being affected. For me, it's really important to know what organs are affected and how severely they're affected, because that goes into this third step, which has to do with, does my patient need therapy? And this is a really important question because sarcoidosis, although present, doesn't always need to be treated. Sometimes the treatment does more harm than good. Some of you may have experienced that, being put on high doses of steroids, wreaks havoc on your blood sugar and your blood pressure, your bone health, your ability to get a good night's sleep, anxiety, all of those things can lead to depression. So not everybody needs therapy. And in the third step, what I decide is, does my patient need therapy? If they do need it, what's going to be my approach? In general, my approach always is the least amount of steroids that we can do. So in terms of the diagnosis part, that first step, there's 3 important aspects to this. And you have to have all 3 aspects of this. Otherwise, you cannot say your patient has sarcoidosis. So do you have the right clinical presentation, the right symptoms? Does it look right? Does it look right for sarcoidosis, or could it be infection or malignancy or something else? Then you want to have histopathologic confirmation. That's where the biopsy comes in. Do I have skin or lung or some lymph node that shows the right kind of granulomas? So that's the second part. Have I excluded other diseases? And I'm going to show you a list in a little bit. I think I kept that slide of all the other diseases that can also cause granulomas that you have to think about to make sure. Once once you've checked marked all three of these, the right clinical presentation, the right pathology, the right kind of granulomas, and exclusion of other diseases, then you can say your patient has sarcoidosis. So I just, I made a list of some of the testing. Probably most of you have had a lot of this stuff. Usually starts out with a chest x-ray, and then it goes into a CT scan, and the first day you go into the clinic, there's probably 5 tubes of blood that you're having drawn to do lots of different kinds of blood tests. There's usually an EKG or an echocardiogram. MRIs of the heart are a really common test as a part of the evaluation. Some of you may get PET scans. Some of you initially might have been told, oh, we think you have lymphoma, and then you got sent for a PET scan, and then you got a biopsy, and then they said, well, it's not lymphoma, it's sarcoidosis. That happens a lot. That happens very frequently. And eye exams. Most of you are probably used to getting yearly eye exams. So I really like this table from this paper that was published in 2015 to give you guys an idea of how we think through this. Because as one of my colleagues, Dr. Judson, says, a diagnosis of sarcoidosis is arbitrary. And I know that's really kind of hard to hear, but because there's no specific test so far that we say that tells you with confidence that this is what your patient has, we sort of look at the clues, and that's what I say. And there's some clues that give you more confidence and some clues that give you less confidence. Now, I take these things with a grain of salt, because in my clinic, when I worked in Cleveland Clinic, my clinic was primarily Caucasians. Down in Florida, I have a mix of 50-50 African Americans and Caucasians. So I always take these things with grain of salt. So things that increase your confidence that your patient has sarcoidosis. So if you're a patient, a United States African American patient, or of Northern European descent, if they've been non-smokers, if they don't have symptoms, if you're symptom-free, but you have findings on your chest x-ray, that gives you more confidence that your patient could have sarcoidosis. That's from a really elegant study in the 1970s that still is one of my most favorite studies. A positive family history of sarcoidosis. So if you have a brother, a sister, a cousin, that makes it more likely. Symptoms involving more than 2 organs. So if you have lungs plus the eyes, or the lungs plus the skin. Sometimes when I don't know if my patient has sarcoidosis for sure in one organ, I go hunting to see if I can find it in other organs. Because if I can find it in one other organ, that increases my confidence. So, that's another thing that I use. Things on exams, so for example, inflammation of the eye, facial nerve like Bell's palsy, having Bell's palsy can sometimes be a sign of sarcoidosis. Lupus pernio is a manifestation of sarcoidosis that is on the face, and it can be unfortunately very disfiguring. Different lab tests. So I just kind of wanted to give you guys, I'm not showing this table just to say, oh, this is what you should know. I'm just saying, I want you to understand how doctors approach diagnosing sarcoidosis. So anyways, I wanted to point that out. So let's talk about biopsies a little bit. There are situations in patients with sarcoidosis when you don't have to do a biopsy. It's not that every patient has to have a biopsy. There's a form of sarcoidosis called Lofgren syndrome, which you can make that diagnosis, which, usually patients have fevers, they have joint involvement and bumps on their shins. If you have that triad, you don't need a biopsy to say those patients have sarcoidosis. But if you have a patient whose presentation isn't typical for sarcoidosis, if you think treatment might be required if they do have it, and if their clinical course doesn't improve or stabilize, in those patients you should think about having a biopsy. And the things that you should biopsy are the ones that are easily accessible. A lot of times that happens to be the lungs, so patients get bronchoscopies because it's a relatively safe procedure, or skin biopsies. Skin biopsies are safe, relatively safe. And then we also say, sample intrathoracic disease because the lungs are usually involved. So this is the table. This is from that paper I was telling you from 1999 that defined sarcoidosis. Look at the list. So here's across the top here, it says lung, lymph node, skin, liver, bone marrow, and other. So let's say I biopsy the lungs and I get a granuloma. These are the other things that I need to make sure my patient doesn't have before I can say they have sarcoidosis. That list is huge. There's infection on there. So these things are inflammatory problems. These are immune system problems. This is an exposure problem, beryllium, titanium, aluminum. Autoimmune problems. So if you have let's say you have a lymph node that has a granuloma, these are all the other diseases you need to consider before you can say and rule out and exclude before you should say your patient has sarcoidosis. So it's a challenging diagnosis, and probably most of you guys have encountered, delays in your diagnosis, and some of that has to do with the fact that it can look like so many things, so many other things. So I'm going to go into the treatment part of my talk now. Very quickly, what I think about when I am deciding if my patient needs treatment is, I ask myself, what are the symptoms that my patient has that I can directly attribute to sarcoidosis? And the reason that's important for me is because sometimes the most bothersome symptoms are not due to sarcoidosis at all. It's from something else. So it's really important to tease out what are the symptoms that are caused by sarcoidosis and what are not. And the example I always give my patients is heartburn. Just because you have sarcoidosis and you have heartburn doesn't mean heartburn is caused by your sarcoidosis. It's because heartburn is pretty common. So that's a very simplified example. So I ask myself, what are the symptoms that is caused directly by the sarcoidosis? How severe is it? So how much is it interfering with my patient's life? How bad do the tests look? And will giving treatment improve that symptom? So the example I like to give for that is fatigue. Fatigue is a problem very common to my patients. They suffer from it significantly. It causes them to have a poorer quality of life, miss work, all kinds of things. The problem is we don't have any medications, at least sarcoidosis specific medications that treats fatigue. So we usually try some other things like exercise and treatment of sleep apnea, and we try to do different we use different techniques to sort of treat that. And then the last question I ask myself is, what are the risks of treatment, and are they worth the benefits? Sometimes prednisone is worse than the disease itself. And so I like to ask myself those questions. I just made a list of some of the drugs you're going to hear about later on, and with that I'm going to end.